everybody. Welcome to our first ever interview of the podcast that we're starting, Jeremy Alvarez TV. And my first guest is Adam Sedati.
How's it going, guys?
So Adam has some pretty cool topics for us that he wants to talk about. He has been shadowing a surgeon and is seeing some really cool stuff in person, some surgeries, and also in the clinic conversations that he's having with the patients before they even go into surgery. So he's got a lot of questions. I'm more on the sports medicine side of stuff, conservative treatment. So fire away, Adam. Let's do this.
Yeah, I'm kind of excited to see the overlap between these two types of treatment. But so the first thing I wanted to talk about a little bit was stem cells. I don't know if that's beyond your realm of what you specialize in, but essentially what they're finding out is this kind of treatment with a lot of these surgeries that helps recovery, where they take some bone marrow from one of the uninjured parts of the body, let's say like the iliac bone or whatever, and they centrifuge it, and then they use some of the parts of that centrifuge. I think the plasmid, I don't remember exactly, but they inject it into the injured site. And I wanted to hear your thoughts on that, if you have any input.
Yeah. So I actually learned a lot about stem cell recently. So I'm going to see if I can pull some stuff up real quick to refresh my memory and like talk about it. But just right off the bat real quick, with stem cells, the one barrier that, you know, it does have some interesting things going with it, but the one barrier is the feasibility of use, right? It sounds great, good idea, but is there an infrastructure for it to where we can do it cheaply and quickly for a lot of people? You know, is it feasible to do? Is it something that we have the staffing for our already overwhelmed healthcare workers to do with everybody? So that's the first part that I think about. And also, you know, that's the biggest barrier that our research is kind of telling us right now. And we're still learning so much about it. But now the bad news is out of the way. The good news is that, the evidence is pretty strong for it. It is helping out. And like you said, like getting some of the bone marrow, right? Getting in there on the uninjured side, pulling it out. We all know that, maybe not all of us, but red blood cells are created in there, right? That's where our stem cells are at. So there's healing properties in that material that we pull out. So it's really cool. Yeah. Centrifuge it, pull it out, inject it, helps promote healing. And that's great. But now let me give you my perspective. So stem cells and PRP, therapy and many other different little areas, types that have been researched and utilized. It's been around for a long time. So this isn't a new thing. So I can't give you an exact number, but I feel like it's been around for at least like 20 years. And why hasn't it been implemented? Well, there's a couple of reasons. Number one, like our translation from research into the clinic is horrible. It's the worst. I'm not sure about other countries, but our healthcare system here in America, it's the worst. It takes like 7 to 14 years on average for research to translate into clinical practice. So that's that. The other thing that I think about is like, okay, cool. You found this great therapy. You heal the injury. You help promote healing. The person feels pain-free. Great. Now what do you do? Right? Like, what does the surgeon do now is my question, that you're able to do it. Maybe you found a way to bill it. You know, people can afford it. It becomes a common thing that we're all doing. Yay, it's the savior magic. Okay. But how did you get the injury in the first place? How were you moving? What were your movement habits? What was your movement lifestyle? You know, what is your movement timeline in terms of like, do you sit around all day? Are you very active? Are you too active? Are you doing the same thing, same sport, one thing over and over again, or same weight training program over and over again? You know, how did you get hurt before? Because it's insane if you apply this great treatment, this great therapy, and then you go back and you do the same thing with the same mechanics, same patterns, and then you cause the same problem again, right? And now you're gonna have to go back and then pay a lot of money and get it done again. and it's almost like a waste of treatment. So
Yeah.
what I would suggest, like in my mind, with all the barriers aside, if we were found a great way to implement this into practice, and then the surgeon that you're working under right now then refers them to somebody like me, then I would help to ensure that the therapy actually follows through and does what it's supposed to do. That's
that's a great take on it. It sounds from what you've told me and what I've just heard, because I was looking into it a little bit before I talked to you about this, that it seems like something that shows some promise, but it's a lot of times not the path of least resistance for these patients when you have something like preventative health care. And on top of that, I don't think it's covered by insurance yet because it's considered experimental. So I think for the man I was shadowing, for the doctor, it cost $3,500 out of pocket to pay for that. So there's definitely there's a lot of situations where it's not really your best bet when you could just prevent it to begin with.
So the PRP, for some reason, it had a brain fart. For everybody listening, it's plasma. I've had a brain fart again. Platelet-rich plasma. Excuse me. So yeah, those platelets are, the blood platelets that carry oxygen and nutrients and stuff, and then basically pump it in. So there's fresh new nutrients that help promote healing. So anyways, there's that. But the thing that, I know we've talked about this off camera. The thing that really excites me is that, again, number one, like you got to get somebody moving better. You can come up with any treatment or, I love, massage. I love all the modalities we use. I love like all the tools we use to, promote healing and all this stuff. I love it. But it means nothing if you don't follow up with addressing the root cause problem and retraining the movement patterns that cause the injury to occur in the first place, right? And I'm discussing more about like non-contact injuries and stuff like that. If you have a contact injury, like someone hits you or something, that's different. But even then, let's now I'm going down this road real quick. So let's talk about, we obviously non-contact, you're moving wrong, there's something going on, maybe not wrong, inefficient, and we need to fix that. That's obvious. We can talk about that next. But just to get this out of the way, when it comes to contact injuries, someone kicked your thigh, right? You have a huge bruise and you can't move your leg, whatever. Okay. Yeah. They need to heal on their own and everything. But in the timeline that their leg is healing, they're probably walking with a limp. They're for sure not using their leg like they normally were before. Right. And the problem with that, even with a contact injury, is that after the tissue heals, right, it takes a few weeks, even if you use PRP, whatever treatment you want to talk about that I listed, whatever modality to take pain away, and they start to put weight on it again, they feel fine. Sometimes the brain retains that pattern that you were using and carries it forward. And now a contact injury, what you couldn't help, right, now creates a bad movement pattern for your future movements. And so you still need, that neuromuscular motor control training. You still need somebody like myself to help to ensure that this isn't the start of a bunch of injuries that are in your near future to come, right? Let's just nip this in the butt. Let's not let this be the start of some injuries to come for you.
Yeah, it's when you said that, it made me think of something that I found kind of funny because back in the day, I don't think they do this anymore, but like with the ACL treatments, I think they used to keep you immobilized in the cast for a very long time, like 6 weeks or something like that. And it turns out that back when that used to be the case, a lot of these patients who would actually not listen to the doctor, not advising that you do this if you ever get injured, but if they didn't listen to the doctor and they actually let themselves out of the cast earlier, because they were moving around, they actually tended to do better. Once again, I'm not endorsing that you disobey your doctors, but it kind of comes to show that a lot of times, like this movement pattern, like as soon as your body is capable of doing it without re-aggravating your injury, it kind of kind of establishes the setting for healing better in the long run. So it's interesting how our bodies work like that.
Okay. When I want to talk about this real quick. So for you in your future career, if I can pass down some information to you, you know, my mentor, he was so awesome. I wasn't really a school person, but when I had this professor in college, I don't know what it was. Like, he just really clicked it in my head for me that, whoa, I understand. I get what you're saying. I see, like, everything so clear to me. Right. And from there, I just took off from there, you know, like there's no such thing as burnout for me, because I just fell in love with this profession, you know, and it's
there's always something to add to what you already do.
And it's awesome. So the one thing he told me was to thank him, is to pass it on. It's like, whatever you do, pass on the knowledge and all that. So one thing I want to talk to you about is that when I'm answering these questions and I come up with these thoughts and everything, what I'm doing is like taking what you're giving me and filtering it through this process. And my filter is my philosophies, right? My filter is, you know, this thing that you can apply any topic or subject to, and what the output is what I spit out of my mouth, right? So one of my philosophies that I want to pass on to you is patient-centered care. So when you provide information to me, one of my filters that the information passes through is patient-centered care. So when you say that, you know, they're starting to do this and you learn about the treatment of this, right? You've maybe, I don't know, I'm assuming hadn't heard about the stem cell stuff before, but now, you know, anytime in the future you hear about anything brand new, you got to filter it through your kind of bullshit filter, right? Is this bullshit or not? And so one thing you got to remember is that with patient-centered care is that this stuff might be amazing for one person, right? Like maybe movement training and all that other stuff like didn't help them. But as soon as you use PRP or some other stem cell treatment, like they were healed, they're better, they can move better, and they'll swear by it, right? And you know what? They're right. You know, like you have to understand patient-centered care. This isn't for everybody, right? Obviously, we've talked about financially and like other barriers, but physiologically as well, some people are just not going to respond to the treatment like others, right? Same thing with movement, right? People are not going to respond to the same exercise the same way, which is why I hate when everybody pulls out in my field, oh, you have weak glutes. They pull out this folder from a filing cabinet, 3 sets of 10 of glute bridge or whatever. It's like, no, like that exercise may have been good for somebody that you worked with and they went back, you know, faster than you helped them and they went back stronger and better, but it's definitely not for everybody. So you have to, you know, be a good clinician and understand that, you know, patient-centered care, this isn't for everybody. So that's the other filter that I filtered it through. And when you're reading research and appraising the research, by the way, I'm going to post some articles and some research that I found or that I had already saved on plasma-rich protein and some other stuff that I've gone over. And maybe we could talk more about this on a future podcast too.
That's a great idea.
Yeah, we can get real into it. But so you can read that and whatever the latest research is. But yeah, just understand this isn't for everybody, and that maybe for some people you need a combination of that plus movement, you know, therapy, movement training, or maybe you just need one versus the other. Maybe somebody can get away with not paying $3,500 and just do movement and benefit from other stem cell promoting activities that have been researched, right? Like I know we've talked about the piezoelectric effect and how that has healing properties just by movement, right? And the more movement of the body parts you can get going, you know, the more healing properties that occur through this piezoelectric effect process. Piezoelectric effect. It's a cool word.
That's a tongue twister there, isn't it?
Yes. Yeah. So you can post some research about that too. But anyway, so there's so many things out there, right? And in science, you're going to read and hear about a lot of cool things, and I love them all, right? Don't think one is better than the other because patient-centered care, okay? It's the best advice I can give you.
Yeah. No, I appreciate that. And I think, shoot, I lost my train of thought. Speaking of brain farts.
Well,
No,
I was
I don't know
gonna
if you can really expand on this.
go.
What were you going to say?
No, go.
Oh, okay. One thing that I learned, and I didn't know this until like earlier this week, but I didn't know that ligaments and tendons are both made of collagen. Like they kind of consist of really, really similar materials, because I was watching this surgery where this was an ACL reconstruction. And what they did is they took some hamstring tendon and they actually created a new ACL with that hamstring tendon, which I didn't know that both of them can kind of be, I don't want to say used interchangeably, but I didn't know that they had so much overlap.
Yeah, the properties are very similar and can thus perform the same duties or similar actions. So, man, that's a whole nother rabbit hole we can go down too, that plenty of people have talked about and stuff, like, do we use autograft versus allograft, which basically means, do you take it off a dead body or a living tissue, or do you take it off like, your own body? What is more detrimental to your own body, like taking your own hamstring or your own patellar tendon, or, I may have took off this piece of collagen like you're talking about, replace my ACL, but now, my hamstring or my knees, now having to compensate for its lack of, function and stuff. So,
because like on one hand, if you take it from your own body, there are no complications with like your body recognizing that tissue as a foreign substance. But at the same time, I mean, to think that your hamstring tendon is going to go unscathed from being taken off a piece of it, that's also kind of a bold thought process. So it's one of those things in biology where you were saying it's not going to be, there's no cookie cutter one size fits all. Like some of those treatments can be better for some patients versus the other. So,
all right, you ready? I'm ready.
Yes.
I'm ready to explode right now. Okay. So,
all right.
So I think this is an interesting conversation that many professionals in my field have, right? What tendon, where it's at, the strength, blah, blah, tensile forces. And I think it's, valid. I think that's a good conversation to be having. But I think the most important conversation we need to be having is preventing the injury in the first place. Like using as much of our tools and repertoire to prevent surgery from happening if we can. Okay. And more of like the entering of the movement training that we're getting if we do have to do this afterwards. Okay. So more of our conversation needs to be more towards that, right? Like you could put in a strong tissue in there, right? Like I can pull this hamstring tendon out, like you're talking about, pull it on a machine and pull it apart and measure its tensile force. It's going to be crazy, right? I mean, thousands of tensile pounds of force, right? But how come they still tear, because it does happen. How come it still tears when a soccer player, does a cut and they re-tear their ACL with that 1,000-pound? You're not telling me they're sprinting and slow down to put 1,000 pounds of force in that hamstring tendon, right? So I think the most important thing we need to talk about is not what, the tensile forces of it are. The most important thing we need to talk about is how is that working in unison, in conjunction with the rest of our body to create movement, right? And to create movement, I think we often forget about, and I love this word, the sensory motor system, right? So we tend to forget about the body reacting to the environment that we're moving in, right? So that's the real things. We need that tissue to not, of course, be strong, but we need that tissue, more importantly, to reflexively act on what, we're doing in unison, right? It's kind of like, here's my analogy. It's kind of like getting a star player, traded onto your basketball team. Like, okay, great. We obviously know this player is awesome, right? But we've seen plenty of teams with star-loaded teams with all-stars fail, right? And like lose to other teams that have less star power.
Yeah.
And so that's what's going on here, right? So what we need to focus on is work more on that chemistry, which is, all the body parts moving together. And the more efficient that we can make someone to move together, the more successful the injury is going to be. And a lot of our research right now is not looking at that. A lot of our research now is looking at success as in the tensile forces, what tissue we're using. Does that make sense to you? And like, we shouldn't be looking at that. We need to be looking at the chemistry of the body and like how the body moves together. That's what we need to be looking at. So, if I were to redo all of those studies again, which I think they're good still, right? Because it led us to this point. But if I was to redo them and follow back up, what I would do is, take a hamstring graft, right? Put it into somebody and then measure their movement patterns, right? And have them go through their season or activities, whatever it is, and then come back and retest their movement patterns. And from there, we can start to get a measure of their physical literacy, of their movement competency. And now I bet we'll find some interesting stuff. I bet the people with really good movement competencies, my hypothesis, the people with really good movement competencies and good physical literacy, the people that were able to build that team chemistry with that star player are probably going to have more success, regardless if it's a hamstring or patella tendon or who cares, whatever other tissue it is, right? That's my hypothesis. Yeah. And I think that's far superior and where the conversation needs to be with regards to ACL tears and reconstruction. That's it
100%.
That's it there.
I think that shadowing a surgeon while you learn a lot, it kind of encourages this thinking that a lot of medicine should be this like treatment once the problem's already happened, once your ACL has been torn. But I think I like that you mentioned that in medicine, the best treatment is preventative. I mean, nothing wrong with researching like these advanced, like invasive methods, but I think you also have to remember, I mean, like it would just be better to make sure that these stabilizers in a patient's hip and knees are functioning properly before you look into, how can we create this makeshift ligament where the ACL used to be?
And you know what? I'm preaching to the choir here. I mean, all healthcare professionals are probably screaming right now, I know, right? Like, I agree. Prevention's the best thing. I agree. And then they go to work, clock in, see their first patient. And guess what? They don't have time. There's no insurance code to charge. There's no I mean, it's impossible to have my business running, to have the lights on, the AC going, especially during summer right now, to have all that going on and to see people and feed my family back home, right? In our economy that we live in right now, by applying what we just said, we think is the best thing. So we have tons of really smart healthcare professionals out there. So by no means, if you see someone in practice not doing injury prevention and focusing more on acting on, being more reactionary than proactive, right? Which is what we think, and they definitely think should be going on. They can't. Our healthcare system does not permit that, right? You said it earlier. Insurance companies still, aren't trusting, this PRP stuff, right? Because they're not going to cover it, right? They're not worried about being proactive. They're worried about what works right now. They're worried about what's safest. They're worried about just reacting, right? Oh, your blood pressure is borderline. Come back to us when it's like over, when it's hypertension, when you have hypertension. Then I'll prescribe you some medication so I can make money off the medication. It's like, it's not the clinician's fault. It's not, any of these people's fault, right? I guarantee most 99% maybe of clinicians would come on here and say, yeah, prevention's the key, blah, 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 complaining, right? But it's not their fault. It's the healthcare system that's the problem. So that's one thing. Go ahead.
Oh, no, I was just agreeing with you.
Yeah, I mean, that's one thing that, as an athletic trainer, that I like is that we have a lot of freedom. So yeah, we have some laws from state to state that we need to follow and all that, but we do have a lot more freedom to see people for longer, to implement prevention programs, to, do a lot of these things that other clinicians are backed into a corner with laws and bylaws that they need to follow to make money. So that's one thing about athlete training that I really like. And you could take it as far as you want, right? You just have to be creative in how you implement it.
Yeah, no, that's a really good thought. I like the kind of what you were talking about there. I have one last topic I wanted to get into for today. And since we've been really focusing on treatment as opposed to preventative healthcare just in today's discussion, I understand it's not the way to go most of the time, but just for the sake of, keeping it in one section, I wanted to talk about hot and cold treatments. I know that's a little bit more basic than the whole stem cell thing, but what type of treatment would you, or what kind of situation or injury would you apply like the hot and the cold treatment? Because I remember seeing something a long time ago where they were kind of alternating them. And I know obviously for your more chronic long-term issues, it tends to skew towards the heat, and then the more acute injuries tend to skew towards cold injuries. But is there some sort of intersection where both can be useful at the same time?
Okay. So besides patient-centered care, my biggest career advice to you, my second career advice to you on this podcast is going to be, practice EBP, evidence-based practice. Our evidence-based practice is composed of 3 parts. Okay. 1, your clinician experience, right? What have you seen worked with the population that you're working with, right? You work with collegiate athletes, this always works. Or you work with older people, this always works, right? Number 2, what is the evidence telling you, right? What are the latest, not 1980s, not 1990s, right? Within 5 years at least, like 5 years old of evidence, what is it telling you, right? Quality, peer-reviewed, preferably systematic review, research telling you about the modality or intervention that you're trying to implement. Okay. The last thing is patient preference or perception. Okay. So if the evidence is telling you, ice is amazing, cold is amazing, cryotherapy is the best, and in your clinical experience, like with your population that you've been working with in your field, and for the thing that you do, you're a surgeon, you're an athlete trainer, whatever, right? Ice has been amazing, right? Everybody's responded well. But the patient comes in and this one patient says like, I don't know, Adam, I don't feel comfortable with ice. It kind of freaks me out, whatever. Or maybe they have a cold allergy, right? It's like, I'm actually allergic to cold. Then guess what? You're not going to use it. You're going to find something else. So my best advice to you as you grow into becoming a healthcare professional is to always have one of your filters be EBP. All right. And within that filter, you have those 3, your clinical experience, patient preference, and the evidence. Okay. So now with that being said, I'm filtering the ice versus cold thing through that, giving you my thought process here, giving you all my cheat codes. Okay. So when I get ice, number 1, I don't really care. My clinical experience has been that people respond to ice and people don't respond to ice, kind of 50-50, sometimes actually my clinical experience is that most people hate it, but they feel like they need to do it because they've been told since they're in elementary and high school and every club they've ever been in, I got to ice afterwards. So they think so they think it's a part of culture. But when I ask them like, who's ready to ice bath or who wants a bag of ice? They're like, I guess so. And they look so miserable. People that I'm sure you've seen people or yourself like sit in a cold tub. Everybody's like, this sucks. I hate this. Right. So in my clinical experience, and then I'm also noticing that, they're getting really tense, right? I can see their white knuckles, I can see their neck muscles, like they're just getting tighter. Right. And it's ironic because you're trying to loosen people up from being sore and stiff and, out of pain. And, when you're in pain, you're holding your ankle, you're holding your shoulder, right? So it's ironic because you're trying to get them to do the opposite. Anyways, that's what I got to say about my clinical experience. What is the evidence saying? The evidence is saying it doesn't do anything. The evidence is saying that sure, it numbs the area for a little bit, but they haven't really shown in plenty of systematic reviews and up to date systematic reviews, I think as of 2018 or 2020 even. Yeah. Even as recent as that. But I mean, they've even been saying this since like there's articles in there from like the 80s saying, this isn't doing anything. But for some reason, my field, we just love ice. So, and we just, and every high school coach and every clinician, just keeps putting it on there. But anyways, that's, and insurance pays for it too. Maybe that's why. But, anyways, the evidence is not very strong for it. Okay. And then, patient preference, I think I already kind of answered that. Like most everybody's like, I'm good. I don't want it. Right. So, and some people are actually like, I need it. I can't not play tomorrow if I don't have an ice bath. I need it. It's like, okay, if you want it, go for it. Because
almost logical to some of them.
Yeah, because and the reason why I say it's okay is because the evidence is telling us that so far it hasn't caused harm to anybody, right? It's not like injuring people or stuff, and it's definitely not helping people either. So it's kind of neutral. So in my experience, it's like, hey, look, if you want ice, I'm not going to argue with you. Go fill up the ice bag or whatever. But you know what? I have bigger things to worry about and more things to think about than to just like ice bag. And in my preference, I would rather say, if someone says, do you think I need ice? I always tell them like, you know what? You don't need it. But if you like it, you want it, sure. But there's more important things we can be doing with these 30, 20 minutes that you have this ice bag on your leg. When you have ice bag on your leg and stuff, you're just sitting there, right? For 20, 30 minutes. And most of the time people are sitting there, on their phones, right? They're like necks forward, they're in horrible posture for 20, 30 minutes. And then they go home, and they're like sitting on their couch, watching TV in the same posture. So what I say is like, no, like it's not the ice that I'm necessarily looking at. It's like the amount of time that they're spending in that poor posture that I'm looking at. So I'd rather have them up and moving and not be given a bag of ice that the evidence has shown is not that great. So EVP, there's that. When it comes to heat, very similar thing. Those moist hot packs that we put on people and clinics and stuff, dude, it only heats like 2 to 3 centimeters beneath the skin. It's not even reaching the muscle belly. Come on now, give me a break. And the goal here is to like heat up the tissue. But I tell you what it does do. It does touch the skin, which has a lot of proprioceptors and they're very important, right? Our skin is very important. We'll talk more about that later. But this thing can really influence how our muscles relax or tight, right? They're in a sympathetic or parasympathetic state. So sometimes heat feels very good on the skin. And when you take it off and the heat's evaporating off your skin as your body works to cool off the tissue that the hot pack was just on, sometimes it feels pretty good, right? So the idea is that, blood flow, heat it up, increase vasodilation to the area, blah, 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 blah. Like you see that redness on the skin. No, it's not. It's not even reaching your muscle belly. The number one way to heat up your tissues is movement, right? When we move, when I do a squat, when I move my arms, when I do any movement at all, right? My muscles are contracting and relaxing. And when my muscles contract and relax, they're sucking blood from the heart, right? And thus the heart has to like start pumping to work harder, right? So our heart doesn't pump blood to the tissues. Our tissues pull blood from the heart. Okay. So that is cardio, right? So when we're trying to heat somebody up, I'd rather have them go through movements because of all the benefits that we've sort of mentioned and we've been talking about through this podcast, right? I'd rather have them go through movements and kill 2 birds with 1 stone than spend 20 to 30 minutes heating or cooling somebody down while they're sitting in a poor posture that's teaching their brain a poor, a poor neurological connection to those tissues that they're already in 23 hours of their day, right? So the best thing that I can do as a clinician for my patients is to get them up, get them moving. It's going to heat their tissues up. It's going to get the blood flow going. It's also going to train those neurological patterns that we're talking about that you're going to have to do either way. So you might as well spend your precious time with me and your money with me, helping you to learn these new movement patterns that at the same time I know are heating up your tissues, right? And if you really like hot packs or heat or anything else, then I'm okay with that too. But I would suggest that you do it after your warm up, because if you heat up internally, you can use the hot packs to kind of retain that heat inside of you, right? So that's the way that I utilize heat packs when I filter it through my EBP process as a clinician.
Yeah. And I think that's an especially good point when you talk about how, like, with a lot of these medical professionals who get paid by the hour that only have a certain amount of time with the patient, it would be way more efficient to jump in and just moving around than just like killing 20 minutes, just putting some heat on the area when they could do that at home. Like that, you don't need a physician to put heat or ice on you.
Exactly. You're seeing it. Yeah. And it's really funny. And my number one pet peeve, I guess I can finish with this. My number one pet peeve is like, okay, they just got hurt recently. They're in the inflammation phase, right? We can't really do a lot of movement because they're still hurt and movement kind of bothers them. And it's like, okay, just hook them up on stem and ice. I'm like, that's the laziest thing I have heard. Like, it's just so lazy. And it's lazy for a lot of ways. Lazy because, obviously in the moment, it's like pretty obvious, right? Like, okay, you're not going to spend time like, helping them or coaching them through something or whatever. You're just going to say, I'll get my ice bag, send them home, or get them my ice bag, let them sit there for 20, 30 minutes and then go home. Like, that's all you're going to do. And then it's also lazy because you didn't do your homework before. Right. If you're in the medical field, you have to do your homework every day, all day. It doesn't matter if, what I learned in college is definitely not what I do right now. Right. Science is always changing, right? Science is always changing. We're always learning new things. We're always having these great questions and researching them and finding great answers, but it's up to us to translate that into practice, and you can't be lazy. And I think if you're in this field, you got to really love what you're doing. And if you really love what you're doing, it's not work. And to me, I promise you, this isn't work. I love what I do. I think it's so interesting. And I feel like I was put on this earth to do it, So because of that, it's like, I think you're in the wrong field. I think you're in the wrong field or the wrong place if you're not excited about, implementing, if you're just still practicing old stuff. It's also slightly negligent too, right? So you want to provide the best care for all your patients, and obviously, maybe they still feel like they're helping people and doing good, but you can't be lazy, man. You got to find time to do this. And we all are offered CEUs every year, where we have to have CEUs to maintain our certification, which is great. But a lot of times people just like, buy like the easiest ones online and just watch a quick video. Don't even watch it. Just play it in the background and just move on, because they think that they've already learned everything they need to learn. It's like, no, there's so much more exciting stuff out there.
Yeah. It sounds like for some of these doctors, there's kind of this combination of arrogance, but also stubbornness, when it's okay to admit that in this medical field and just in science in general, we don't know everything. Like every year there's something new being found out, and it'll be that way kind of till the end of time. So
one of my, a lot of my mentors right now, one of the top researched questions that they're unwrapping right now is the topic of unlearning. So they're trying to figure out, it's like, why are people struggling to unlearn? Is it, I don't know what it is, but something's going on where people are not letting go of what they've learned and they're struggling to unlearn. And so anyways, keep an eye out for that research that's coming out. Shout out to Dr. Kaylee Welsh-Bacon. She's the one doing it.
Oh, that's awesome. Yeah. Shout out to her indeed. I think that's all the topics I had to cover for today. Thanks for taking some time to talk to me about that.
Cool, man. Yeah, not a problem.
Yeah.
Thanks for all the questions. We'll do this again.
Yeah, no problem. 100%. All right.
All right. See you, Adam. Have a good day, man.
Take care.
Hey, everybody. Thanks for watching Jeremy Alvarez TV. For more health and wellness tips and content, please subscribe to Jeremy Alvarez TV.
Perfect.